Let us now turn our attention to health information technology governance. This concept signals a shift from the broad policy landscape we examined a moment ago toward the practical art of stewardship. In the previous segment, we discussed how digital infrastructures can sharpen clinical insight. Now we must ask who charts their course and to what end. Health information technology is far more than machines and code. It is a strategic lever that, when wisely governed, accelerates quality improvement, broadens patient engagement, and safeguards the long-term viability of our organizations. Effective governance supplies the compass. It aligns every analytics project, interface build, and infrastructure purchase with institutional purpose, weighs competing requests openly, manages risk proactively, and requires proof of value. Sound governance also nurtures creativity by establishing transparent rules for experimentation, allowing promising pilot work to mature into enterprise practice. Where such discipline is absent, investment drifts, innovation fragments, and vulnerabilities proliferate. Imagine a mid-sized rural hospital eager to introduce remote patient monitoring while also replacing an aging electronic record. A governance council that convenes clinical leaders, financial officers, security specialists, and community representatives can map both ambitions against the strategic plan, estimate the benefits and burdens, and sequence the work coherently. The Council might choose to modernize the record first, building the interoperable data foundation on which remote monitoring will depend, thereby conserving capital and limiting disruption. For you, as emerging health managers, the implication is unmistakable. Mastery of governance principles is not a bureaucratic exercise. It is the discipline that converts bold digital vision into safe, sustainable, and value-driven care, and it is a hallmark of leadership in 21st century healthcare. The objectives for this module frame the aims that must shape any program of health information technology governance. First, we must articulate why governance is indispensable. Digital tools alone do not guarantee safer care or streamlined billing. Without deliberate oversight, resources scatter, data standards diverge, and risk multiplies. Describing this vulnerability and the safety and equity gains that governance unlocks is the first step in any dialogue with a board or clinical council. Second, we must identify the foundational elements that sustain a governance structure. These include a charter linking every decision to institutional strategy, transparent criteria for ranking proposals, strong stewardship of privacy and security, and a learning loop that refines policy. These considerations ensure that governance is not a committee in name only, but a living engine of value. Third, we must establish a disciplined approach to providing advice. When asked to recommend a new analytics platform or a telehealth partnership, a governance body should weigh strategic alignment, total cost of ownership, workforce impact, and cultural readiness. Only then can leadership adopt technology with confidence. Consider a community health center that serves a multilingual population. When requests arrive for both a mobile scheduling application and a population dashboard, a well-formed governance council can compare needs, show how the dashboard closes access gaps, and schedule the mobile tool for the following quarter. Rigorous sequencing delivers benefit and strengthens trust in leadership. These objectives convert governance from theory into value for patients and professionals. Let us turn the page to a question that every modern hospital must confront. Why is information technology governance needed? In the previous segment, we outlined the objectives that give structure to any governance program. Now, we explore the compelling reasons that justify its existence. First, governance binds every digital initiative to the mission. Laboratories crave faster analytics, clinicians desire new decision support tools, and finance teams pursue cost control. Without an agreed framework, these wishes compete in silence, and scarce capital drifts toward the loudest voice rather than the greatest need. A governance council calibrated to institutional priorities broadcasts clear criteria, so each proposal is judged by its contribution to patient safety, organizational sustainability, and community trust. Alignment replaces improvisation. Second, governance brings disciplined triage. The demand for data warehouses, security upgrades, and mobile applications often exceeds budgetary reality. An orderly process for ranking projects gives leaders the confidence to say yes later instead of no never, preserving goodwill while safeguarding solvency. This prioritization also exposes hidden dependencies, reducing the costly rework that arises when systems are deployed out of sequence. Consider a regional health network facing simultaneous requests. The imaging department seeks cloud storage for high-resolution scans, while home care services propose a remote monitoring platform. A governance board comprising clinical directors, technologists, and patient advocates may discover that cloud storage will lower operating costs and accelerate image sharing across the network, benefits that in turn make remote monitoring more feasible next year. By sequencing investments, the board maximizes value without enlarging risk. For aspiring or current healthcare managers, the lesson is unmistakable. Mastery of governance is not optional. It is the discipline that converts digital ambition into coherent, equitable, and financially sound care for the communities you serve. Now that we have clarified why sound stewardship of digital resources is indispensable, let us break that stewardship into its essential building blocks. The heading before you, core components of health information technology governance, signals a shift from rationale to architecture. First, every organization needs a structure that voices its purpose without ambiguity. The board of directors, joined by senior executives, must translate mission and community promise into a rank set of digital priorities. Their charter states what the future the institution seeks and how technology will help reach it. Second, a coordinating body is required to keep projects and priorities aligned once daily pressures mount. This multidisciplinary council reviews proposals, weighs the benefits against the costs and risks, and selects the sequence that delivers the most significant collective value. By publishing its criteria, the Council turns potential conflict into transparent deliberation. Third, performance oversight must be continuous. Clear metrics for safety, equity, experience, and balance sheet impact enable leadership to determine when a program is succeeding and when redirection is needed. Consider a children's hospital confronted with simultaneous demands for a bedside medication scanner and a new teleconsultation platform. Guided by the framework just described, the board endorses medication safety as the foremost strategic aim. The Digital Council then schedules the scanner first because it directly reduces dosing errors and assigns the teleconsultation build to the following fiscal quarter when the infrastructure team becomes available. Dashboards track error rates and project spend, demonstrating that governance is not a bureaucratic break, but an engine of measurable improvement. For managers in training, these components are more than theory. They are the scaffolding that converts bold digital dreams into dependable, patient-centered, and financially responsible reality. Master these pillars, and you will guide technology rather than be guided by it. Having mapped the essential pillars of oversight, let us now examine how these pillars come together to form a working framework. This slide, Sample Governance Structure, illustrates a model that many successful health systems adapt to their contours. We begin at the summit, where the board of directors, together with the executive leadership team, sets the digital compass. They translate the institutional mission into a health information technology vision, determine the appetite for risk, and declare clear expectations for value, safety, and equity. Their voice ensures that every downstream decision remains tethered to purpose rather than fashion. Beneath that pinnacle stands the Clinical Information Technology Governance Committee, a multidisciplinary forum chaired by the Chief Health Informatics Officer and comprising the Chief Nursing Informatics Officer, the Chief Medical Informatics Officer, and key leaders from nursing, pharmacy, finance, quality, and operations. This council converts strategy into an actionable roadmap, adjudicates competing requests, and monitors progress through transparent metrics. Executing the plan are several specialized work groups that report to the Clinical Council. A medication safety group may oversee barcode scanning at the bedside. A data analytics group may manage dashboards for population health. And a security group may safeguard against cyber threats. Their charge is operational precision. Budgets are met, change management plans are honored, and benefits are realized. Picture a large academic hospital deciding whether to adopt a unified communication platform or expand its genomic analytics service. The Clinical Council weighs both proposals against the strategic mandate issued by the board to improve care coordination this fiscal year. It endorses the communication platform immediately, authorizes preparatory analysis for genomics, and tasks the security workgroup to verify interoperability safeguards. Within 6 months, patient handoffs improve measurably while genomic planning advances without derailing critical resources. For aspiring and current managers, such a structure is not administrative ornament. It is the blueprint that aligns ambition with capacity, balances innovation with stewardship, and delivers trustworthy outcomes for patients and communities. Having just examined how roles and committees interlock within a practical oversight framework, we now shift our lens to the daily choreography that animates that framework. The slide before you is titled the Health Information Technology Governance Activities and Processes, and it captures the disciplined sequence of actions that turns policy into patient benefits. The journey begins with a formal gateway for every new digital idea. Whether a proposal originates from a nursing unit or the finance office, it must be submitted in a standard template that clearly describes the clinical problem, projected benefits, estimated costs, and measurable success indicators. This uniform entry point eliminates shadow projects, ensuring that each suggestion is judged on merit rather than volume. Next comes horizon planning. Leaders look 2, 3, even 5 years ahead, aligning predicted shifts in regulation, reimbursement, and community need with forthcoming technological capabilities. This forward view prevents today's solutions from becoming tomorrow's bottlenecks. Proposals then undergo a rigorous comparative review. A multidisciplinary council scores each initiative against strategic alignment, safety impact, equity considerations, and operational readiness. High-value projects rise to the top, while promising but premature ideas are revisited for refinement. Every change to the electronic health record receives added scrutiny. Alterations are treated as clinical interventions, workflows are mapped, and user training is scheduled, and data integrity tests are run before a single line of code reaches the production environment. Funding follows a milestone model. Rather than releasing an entire budget up front, the Council allocates tranches tied to demonstrated progress, thereby protecting scarce capital and encouraging accountability. Finally, outcomes are tracked through a dashboard that blends financial data with quality and experience measures. If a new bedside medication scanner reduces dosing errors by 40% within 6 months, that success informs the next investment cycle. For managers, mastering this sequence means translating bold digital vision into reliable patient-centered value, day after day. We now move from the mechanics of governance that we examined in the last slide to the human network that makes those mechanics work. Our current focus is coordination and collaboration with diverse stakeholders, a discipline as vital as any software or budget line. Careful orchestration among nursing, pharmacy, laboratory science, finance, and information security ensures that decisions about digital tools are grounded in day-to-day realities. When these voices are absent, organizations risk introducing technology that undermines workflow, fragments data, or weakens safety controls. Conversely, deliberate collaboration converts governance from a policy document into living practice. Risk management deserves particular attention. Cyber threats, insider misuse of sensitive data, and service interruptions require a shared vigilance that transcends departmental borders. When nursing detects early signs of ransomware, pharmacy verifies medication integrity, and laboratory leaders validate result accuracy. The organization achieves a layered defense that no single team could deliver alone. Collaboration is equally crucial for striking a balance between stability and innovation. Academic medical centers, for example, must safeguard electronic records for routine care, while enabling disruptive research technologies such as large-scale genomics or advanced imaging. Only through joint planning can operations remain dependable while laboratories continue to push the scientific frontiers. Consider a regional children's hospital preparing to integrate a voice recognition prescribing tool. A multidisciplinary working group is convened. Bedside nurses map the verbal workflow, pharmacists verify dosage safeguards, laboratory specialists ensure result codes remain unchanged, and the Chief Information Security Officer evaluates privacy controls. By drawing on diverse expertise, the hospital identifies an unanticipated risk. Background noise in intensive care units could alter dictation, then mitigates it with tailored microphone placement and real-time confirmation prompts. The project launches safely. Staff adoption is high and medication error decline. For healthcare managers, the lesson is clear. Strategic alignment is achieved through structures, but sustained value arises from purposeful collaboration across every corner of the organization. Building on our discussion of cross-disciplinary coordination, we now arrive at the principle that welds those collaborations to purpose: governance-driven technology choices. Notice how governance comes first. The ordering is deliberate and non-negotiable. Strategy, values, and acceptable risk must lead, while devices and software follow. Why does this matter for contemporary healthcare management? Digital markets move at breathtaking speed, and vendors frequently promise miracles in exchange for a signature. When leadership lets the glamour of a new platform eclipse institutional priorities, budgets swell, workflows fracture, and ultimately, patients bear the brunt of the cost. A robust governance framework, anchored in its mission and shaped by diverse voices, shields the enterprise from the seduction of shiny novelties and channels investment towards solutions with demonstrable value. Governance also safeguards independence. Counsel must not be beholden to any single supplier or system. Their mandate is to weigh evidence, risk, and benefit dispassionately, then direct technology rather than be directed by it. Consider a community hospital impressed by a trade show demonstration of an artificial intelligence triage tool. The Technology Council evaluates the request against the strategic plan, which highlights reducing medication errors and expanding rural teleconsultation. Because the triage tool serves neither priority and its training data omits local demographics, the Council defers the purchase. Instead, it endorses the adoption of secure text messaging between pharmacists and nurses, a project that directly cuts transcription mistakes and supports remote clinics. 6 months later, medication error dropped markedly, and clinicians praise the streamlined workflow. As future managers, you will face a continual parade of enticing technologies. Your charge is to let governance choose the tools, ensuring that every dollar spent advances mission, reinforces safety, and honors the community you serve. Let us build on our discussion of governance-driven technology choices by asking how we measure progress over time. This slide, titled The Maturity Model, offers a structured lens for assessing how effectively an organization harnesses digital capabilities. Across 5 capability dimensions: managing information, applying business intelligence, deploying information technology, aligning organizational strategy with information practice, and steering change, health system climb 5 distinct levels. At the basic rung, data live in silos and analytics depend on ad hoc spreadsheets. Controlled status introduces policies, budgets, and emerging links between technology spend and clinical priorities. When processes become standardized, shared vocabularies and uniform workflows allow reliable comparison across units. Optimized organizations embed data in every decision. Automated quality surveillance spots variation early, and improvement cycles run continuously. The innovative tier pioneers new care models, weaving predictive analytics, advanced imaging, and patient-generated data into routine practice. Why does the latter matter for healthcare management? Without a maturity compass, leaders cannot determine whether investments enhance care or merely add complexity. By diagnosing today's level and targeting the next, hospitals pace spending, train staff deliberately, and safeguard return on scarce capital. Imagine a mid-sized urban hospital that has recently implemented a unified electronic health record. A candid self-assessment places it between controlled and standardized. Policies exist, yet dashboards remain unit-specific. The leadership team, therefore, prioritizes a hospital-wide data dictionary and shared analytics training before attempting predictive algorithms. Within a year, transfusion reactions fall, length of stay drops, and the organization earns the confidence to explore sepsis alert models, hallmarks of the optimized stage. Mastery of the maturity model transforms lofty digital aspirations into an orderly journey of measurable, patient-centered gains, and equips you as future managers to lead that journey with clarity and purpose. So, the key considerations when forming a new governance structure are as follows. Our maturity model shows where the organization stands on its digital journey. Now we must decide how to guide that journey by designing a council that fits the culture we already have. The first principle is respect. Finance boards, nursing councils, and safety committees have a deep history and a strong reputation for trust. Sweeping them aside to make room for a new digital group breeds resistance and delays. Instead, map existing mandates, identify overlaps, and invite their leaders into the design conversation. Second, think alignment. The new governance council should integrate with the current chain of command, allowing requests to move upward for approval and guidance to flow downward for execution. Clear connections keep projects from stalling in a corridor of competing opinions. Third, reinforce before you rebuild. Often the best move is to add a director of information technology or a clinician who specializes in informatics to an established improvement committee. This approach preserves familiar workflows while injecting needed expertise. Picture a suburban medical center that already holds a weekly safety huddle. Rather than create a separate technology panel, the hospital expanded the huddle to include a nurse informaticist and the chief data analyst. The adjustment maintained the cadence that staff valued and introduced digital insights to every safety discussion. Within 6 months, the team identified a gap in medication barcode compliance and corrected it before it could cause harm. Thoughtful construction grounded in respect, alignment, and reinforcement positions. Governance to earn trust and deliver measurable results. As future leaders, learn to strike a balance between innovation and deference to established voices. Having explored how to launch a governance body that respects existing decision-making channels, let us proceed to the governance assessment. This disciplined checkup keeps the engine running smoothly. The first task is to measure the maturity of your current health information technology capability. Are data silos still prevalent, or has the organization already adopted predictive dashboards? A candid appraisal sets a realistic starting line and prevents overpromising. Next, map the formal structure. Identify which committees hold authority, where escalation paths converge, and how frequently decisions are reviewed. Alongside this official chart, search for informal routes, those hallway consultations or ad hoc task forces that quietly shape technology choices. These informal networks often reveal hidden strengths or bottlenecks that the org chart misses. Then ask what works. Perhaps the clinical documentation subcommittee clears electronic record changes with impressive speed, while budget approvals crawl through 3 redundant layers. Preserve the former, streamline the latter. Additionally, look for elements that reflect the institution's personality. A mission-driven rural hospital may rely on the long tenure of a nursing director who acts as cultural glue. A fast-growing academic center may depend on an entrepreneurially minded chief research officer. If governance hinges on a single person, succession plans and knowledge transfer become urgent. Consider a regional health system that believed its oversight was sound until a ransomware drill exposed sluggish response times. A week-long assessment uncovered that cybersecurity decisions were buried inside a finance committee agenda. By separating security into its rapid cycle review group and adding cross-training for night shift supervisors, the system cut incident response time by half within 3 months. Regular, honest assessment transforms governance from a static chart into a living, adaptive safeguard, one that protects patients, budgets, and the institution's strategic future. After diagnosing our current oversight model in the governance assessment, we now move from reflection to refinement. This slide, Enhancing Health Information Technology Governance, invites us to build a structure that keeps pace with clinical and analytical ambitions. First, enhancement starts with deliberate design. Establish a council with clear goals and sufficient flexibility to adapt as capabilities evolve. Implement the framework, observe performance, and adjust at regular intervals. Iteration turns policy into a living discipline. Second, match the complexity of the governance model to the reach of your technology environment. A critical access hospital may thrive with a lean decision board that meets every 2 weeks, while a multi-state network may need tiered committees and formal subgroups. Oversized structures waste time. Undersized structures invite risk. Third, embed collaboration at every layer. Nurses, pharmacists, laboratory directors, finance officers, and security leaders deserve real seats. Their insight guards against blind spots and speeds adoption. 4. Ensure the governance body reports directly to the highest strategic forum, such as the Board of Trustees or the Executive Council. Visibility at the top secures resources and reinforces accountability. Fifth, design around culture. A rural system might emphasize community representation, whereas a research center could launch an innovation studio that scouts emerging tools and tests them in controlled pilots. Consider a coastal teaching hospital that recently established an innovation group within its governance council. By empowering clinicians to propose pilot projects, the hospital launched a teledermatology service in underserved clinics, validated its outcomes over a 6-month period, and quickly scaled the program across the region. Continual enhancement keeps governance strong, relevant, and truly strategic. Picking up from our conversation on refining and enhancing oversight, the slide before us is titled Summary of Health Information Technology Governance, the final canvas on which we gather every theme from this module. The previous slide urged continual improvement. This one challenges us to synthesize lessons and prepare for rapid change. In this module, we define why structured oversight of digital resources is indispensable, outline objectives that ground decision-making, and explain the forces that require governance in a resource-constrained environment. We detailed foundational components, illustrated a tiered structure linking trustees, clinical leaders, and operational teams, and walked through systematic activities for proposing, prioritizing, funding, and monitoring projects. We emphasized collaboration across nursing, pharmacy, laboratory, and security, insisted that mission, not gadgets, set the agenda, and introduced a maturity ladder for gauging progress. We reviewed cultural and structural considerations when creating a council, demonstrated methods for honest assessment, and offered iterative strategies, including innovation programs, to keep governance agile and aligned with fast-moving clinical and financial modern landscapes. Why is this synthesis vital for anyone managing care? Because reimbursement models, privacy statutes, and community expectations evolve every month. A governance council able to pivot quickly can redirect funds, update workflows, and deploy new safeguards without paralyzing the organization. Picture a coastal hospital that discovers a spike in adolescent mental health emergencies. Within one planning cycle, the council pauses a non-essential server upgrade, reallocates capital to a secure telepsychiatry platform, trains frontline staff, and measures return on reduced emergency wait times. Such agility protects patients and preserves limited budgets. That closes our journey through governance. Review the assigned readings so you can test these principles in practice during our next session.